Today I'll be discussing common pediatric hernias and the treatment implications for children. How are hernias diagnosed? Pediatric hernias normally are noticed by the parent first. There's a bump or bulge on the trunk or in the groin that the parent brings to the attention of the pediatrician. Sometimes the pediatrician will pick up on the hernia at a well visit. Once that's done, a referral is made to a pediatric surgeon. Pediatric surgeon, after obtaining health history and a thorough assessment, will determine if surgery is needed for the hernia or if continued observation is required. In the event of incarceration or strangulation, which we will talk about a little bit later, hernia repair surgery is an emergency and should be done as soon as possible. Pediatric hernias are more common in premature babies due to the underdevelopment of muscles and tissues. The most common pediatric hernias include inguinal, umbilical, and epigastric hernias. Inguinal hernias are present in the groin. Umbilical hernias are present at the umbilicus, or as parents refer to it as the belly button. And epigastric hernias are present on the trunk from the chest to the umbilicus. %80 of documented pediatric hernias are inguinal hernias. There are two types of inguinal hernias. The first one is direct, which is a weakness in the muscle layer. This is more common in adolescents and often known as sports hernias or lifting hernias. Indirect inguinal hernias is what we see most often in our practice. The inguinal canal is supposed to close during fetal development, and sometimes it fails to close after birth, and this allows the intestine or the testicle to slip through that inguinal ring into the groin, and that appears as the bulge in the groin. Females sometimes will present with a bulge in their labia. This area protrudes when the child is coughing, crying, or straining. It may disappear with a relaxation or sleep, or it may not. This is always more common in premature infants because of the underdevelopment of the muscles and the tissue layers in those young preemies. It's 6 times more common in males than females, but females are more likely to have bilateral inguinal hernias than males. Inguinal hernias are also classified by severity of the hernia. Reducible hernias present as a bulge in the groin, and upon palpation, the intestine can be pushed back through the hole in the muscle layer. Reducible hernias are not emergent and can be repaired as a scheduled surgical procedure. Incarcerated hernias occur when the intestine cannot be pushed back through the muscle layer. If the incarcerated hernia has a blood supply that is compromised in its position, the hernia is considered strangulated. Incarcerated and strangulated hernias are a medical emergency, and the child should be taken to the emergency room or the pediatrician right away. Surgery should be performed as soon as possible. Umbilical hernias are often referred to as outies in our culture. The belly button protrudes from the abdomen. The umbilical ring has failed to close after the umbilical cord came off. Reassure parents, this was not a result of how the umbilical cord was clamped or cut off. Okay? The umbilical hernias are equally present in males and females. They're more common in African Americans and more common in premature infants. The hernia will be monitored until the age of 4. Parents are often skeptical about this because they want it fixed right away if they think that there's a hernia. But the hope is that there will be some spontaneous closure of the umbilical hernia, which occurs in a lot of patients before the age of 4. And if surgery is still required at the age of 4, then the fascial defect will be smaller. The fascial defect is the measurement of the opening in the muscle, which is determined by the pediatrician. If in the event of a very large hernia, there will be a special procedure to remove excess skin at the time of closure, and we'll discuss this a little later in the presentation. Can anyone name this animal or what it's referred to as? We can see that it's a monkey, but he has a specific name. This is a proboscis monkey. It is named for its very large protruding nose. Infants and children can have an umbilical hernia which is unusually large and protrudes from the abdomen, similar to this monkey's nose. This is called a proboscoid umbilical hernia. It is hard to explain to a parent that this is not a medical emergency and does not require immediate surgery. If there is no compromised circulation and no pain, the large hernia will be monitored. As stated previously, some closure of the fascial defect over time will make the surgery less complicated. When proboscoid hernias are repaired, there is often excess skin that will need to be removed, which we'll discuss later in the presentation. Epigastric hernias usually occur midline between the chest and the umbilicus. These are a weakness in the abdominal muscles in which fatty tissue protrudes through the opening. Epigastric hernias will not close without surgical intervention. These hernias can increase over time if not noticed or brought to the attention of the physician. Epigastric hernias can be painful to the child, and the hernia can be noticed mainly through coughing, straining, or crying. An abnormality in the second picture here, known as diastasis recti, is often mistaken for an epigastric hernia. It is more common in premature babies due to the underdevelopment of the abdominal muscles. It appears in the shape of a hot dog, as you can see here. It's elongated, as a hot dog bulge from the lower chest to the umbilicus. Diastasis recti will resolve over time. The parent always asks, does my child need surgery? Most hernias can be repaired as an outpatient procedure. In the case of a reducible inguinal hernia, the surgery can be scheduled by the pediatric surgery office. Parents can plan for time off out of school, time out of daycare, or vacations. If the inguinal hernia is incarcerated or strangulated, the surgery is considered an emergency and will be performed immediately by the surgeon. Umbilical and epigastric hernias repairs are scheduled as outpatient procedures. What are the emergency implications for an incarcerated or strangulated hernia? These include these that are listed here but are not limited to them. There is abdominal distension in the baby or the child. There's redness or discoloration around the site of the hernia. Increased pain, sometimes uncontrollable crying in an infant since they can't express their pain. Vomiting, fever above 100.4. Increased tightness with the skin stretching at the site of the hernia, and the bulge will not resolve. You cannot push it back in. This is a medical emergency. Let's talk about the surgery. Surgery is performed under general anesthesia as an outpatient procedure. There are 3 methods of closure for the inguinal hernias. An open method of repair involves a small incision in the affected area to push the intestine back through the opening. The muscle layer is sutured closed, and then the skin layers are closed with dissolvable sutures. If the child is less than 1 year of age, an open sac could be present on the opposite side of the groin. So the surgeon will commonly perform an open inguinal hernia with laparoscopic exploration of the opposite groin. If a hernia is present on the opposite side, then the open procedure will be completed on that side also during the same operation. It is important for surgeons to explain this to parents and include all the possibilities on the consent form prior to surgery. Inguinal hernias can be performed as a laparoscopic procedure also, but the open method is the gold standard for children. Umbilical and epigastric hernias are repaired using an open method, also closing the muscle layer and then the skin layer with those dissolvable stitches. A pressure dressing is placed on the site for an umbilical hernia, and in the case of a proboscoid umbilical hernia, there may be a necessity to remove excess skin that has been stretched over time. This method to remove the excess skin is called a Y to V umbilicoplasty. The initial incision is made in the shape of a Y to assist in the removal of the excess skin, and the flaps that were created are removed and an umbilical valley is reconstructed. A pressure dressing is formed with cotton and compressed pressure to prevent seroma formation. Epigastric hernias are repaired with a simple small incision. Parents are often very nervous about any surgery that their child has, so it's important to go through some post-op teaching for them prior to the surgery. Let them know that mild pain is expected after the surgery, which is usually controlled by over-the-counter medications. There's not usually narcotics required for pediatrics. Recovery time for an infant can be as short as 2 to 3 days, and for an older child, about 5 to 7 days. It's very quick recovery for children. Restrict full strenuous activities for older children for about a month, and let the parent know that there is some swelling that will be expected in the scrotum in the event of an inguinal hernia repair. Follow-up is usually dependent on the surgeon's preference, which is usually about 1 to 4 weeks, and the child should wear loose clothing at the site of the repair just to keep there from being any excess pain or pressure on the site. The child can sponge bathe for a week and then tub bath after 1 week, and a pressure dressing will usually be in place on an umbilical hernia repair, which can be removed in 2 to 5 days depending on the surgeon's preference. After the surgery, the parent should call the surgeon or return to the pediatrician if the patient is unable to urinate after surgery or has a significant decrease in the number of wet diapers, a fever greater than 100.4, excess swelling or pain at the repair site, increased redness or severe bleeding at the site, vomiting, or foul drainage. Also, parents should notify the physician with any concerns of reoccurrence of the hernia. As I said, children recover very quickly from hernia surgery and most types of pediatric surgery. They will continue to be playful and rambunctious as they were prior to surgery. It's often hard to get parents to believe you when you inform them of this with teaching, but they will soon find the hardest part of recovery is restricting the patient's activity. Thank you for your attention today, and I hope you've learned a lot about common pediatric hernias and the implications for their care.